its appearance as a white mass behind the lens. And first described by Terry, who that's why it was also called Terry syndrome originally. In 1951, Campbell suggested the retinopathy of prematurity related to oxygen treatment. So the normal retinal vasculature start developing at 16 weeks of gestation, and nasal retina is shorter, so it's complete vascularized in 32 to 34 weeks. But temporal retina vascularized at term or just 2 weeks after birth in full-term babies. So retinopathy of prematurity develop because when the baby is born, it is in a hyperoxic state. So that downregulate the vascular endothelial growth factors and lead to vascular obliteration, resulting in delay in retinal vascular development. So later on, when the retina become hypoxic, it starts releasing VEGF and cause proliferation of the blood vessel branching, and that you can see in stage 2. So Lester Fielder has research about the birth weight and retinopathy of prematurity, which is inversely proportional. So the smaller the birth weight, less the higher chances of developing retinopathy of prematurity. So worldwide, the preterm rates varies, but it's ranged from 5 to 18%. And extremely premature is like less than 28 weeks. So there are about 15 million babies born every year preterm. So India is the country with the highest number of preterm births, which is like 3.5 million. So world over, there's about 20,000 babies go blind or severely visually impaired from ROP, and further more than 12,000 mild to moderate visual impairment. So in Argentina, it's about 60% childhood blindness is due to ROP, and about more than 50% in Poland and Russia. So in India, about every 2 hours, 3 babies reach threshold disease. So this is a world map by Claire Guilford research. So it's showing 3 colors. So countries in green, which are like USA, Canada, Australia, UK, and Western Europe. The neonatal care is very good, and screening is improved so much and efficient that there's hardly cases of any blindness from ROP now. And compared to, and then the countries in the red, there in these countries, which is like Eastern Europe, Russia, South America, South Africa, India. So the neonatal care is getting better, more survival rates, but the screening and efforts are not as good for treatment, and they are the maximum babies going blind with the ROP. So in the Central African region, the black area on the map is the neonatal care is not adequate, and the survival rates are very low. So that's why babies are not surviving to have visual impairment with ROP. So International Classification of Retinopathy of Prematurity first appeared in 1984, and which was a game changer because before that everyone was recording according to their findings, and but this classification make them write according to the grade and stages of ROP. So it's every 10 years, it's the new classification coming in. And 2005, which is at the moment is the latest, make some addition with describing posterior ROP or aggressive disease, or pre-plus, which is the severity is less than the plus disease. And it also describes how the zones are clinically identified. So the IC-ROP3 is not out yet, but it will be published this year. The complete work has already been done. There's a committee, international committee for IC-ROP, is 34 members, 22 are retinal specialists and 13 pediatric ophthalmologists. They have already given their suggestions and completed it, just in process of being published. So they will describe now new things, which include like this notch, temporal notch, which is present in like zone 1 and zone 2, and how to describe it. They have make some changes in zone 2 and also in stage 4 especially. So this is a diagram of zones of retina. There's no marking on the retina. So clinically, when we are looking through a 28D lens, the indirect ophthalmoscope, keeping the disc on the edge of the field, the other edge is the zone of between zone 1 and zone 2. That's the marking. And if you go nasally, reaching to the ora serrata and draw a circle from that area is all zone 2, and any retina beyond it on temporal side is zone 3. So there's no zone 3 on the nasal side. So the inclusion criteria is any baby less than 32 weeks. So that means babies which are 31 week plus 6 days included into the criteria. So this inclusion criteria is according to the UK guidelines. So it sometimes varies from in different countries. So less than 1501 grams. So the baby says 1501 gram is not included. Babies of 1500 gram or less are included. You only need to meet one criteria to come into the screening. And in addition to this, any baby is requested by neonatologist will be included if his clinical course was not according to plan, or excessive oxygen therapy, or septicemia, or like any reason when neonatologist saying it's necessary to do the screening. So the first screening, according to the gestational age, the smaller the baby, like 22, 23 weeks, you don't need to screen for 7, 8 weeks of birth because the process starts later on. So examination require an indirect ophthalmoscope, 28D lens, dilating drop, speculum, scleral indenter, which can be like disposable or metallic, or squint hook can be used, anesthetic drops, and sucrose for analgesia. In the picture, the syringe is actually sucrose. So it can be challenging at times, especially when the baby is on ventilation or CPAP in the incubator, small space to maneuver, and difficult to get full view. And this is using a red camera to get a fundus image, which is quite critical in especially cases with stage 2 or 3. This I'm using a PanoCam, which is a handheld device again to acquire fundus, retinal images. So I'll give you two examples from my working in UK and Pakistan. So a few learning points. So in UK, between 1985 and 1990, there was about 6% children with childhood blindness are due to ROP. Mainly babies below 1,000 grams. The incident decreased to 3% in around 2000, but in last 10, 11 years, the incidence is nearly zero. And that, in my view, is because of two things. One is called Boost trial, and the other is Benjamin. I'll explain. So Boost trial was, I was part of the trial in data collection, and it was targeted oxygen saturation levels. So then they're comparing the like 85 to 89% oxygen saturation with the death or disability, and also the ROP checked in all babies. So Boost 2 trial with a lesser oxygen saturation was terminated before finish because of higher mortality. But definitely in most of the ROP was less. The other thing was, as the technology advanced and internet developed, there was a software used in UK called Abajanet, which is a patient management network. It is used in neonatal units and maternity units. So all babies' ROP findings are entered into the system, and then the system itself highlights when it's due for the next screening, what was the finding of the previous screening. And the reason why the ROP was missed in UK is not because the doctors were missing, it was because the appointment was missed. Because when they are transferred from one neonatal unit to another neonatal unit, sometimes it was not done on time or completely overlooked. So this, you are from, even when I used to have a login, the baby transfer from like Liverpool to Edinburgh, or from any city to another city, you can immediately see what was the previous findings, and it will already flagging up when the screening is due. So in Pakistan, the picture is of a hospital where I worked. It's a premium institute in Pakistan where I did my residency in 1998. But in 2013, I moved back to Pakistan from UK, working there as pediatric ophthalmologist. So then I visited regional neonatal units, the four teaching hospitals, and was surprised to find that there is no ROP screening service and no ophthalmologists seeing the neonates, young age. This is one of the babies done on laser treatment just with topical anesthesia, because anesthetists said that it's very high risk to do general anesthesia for them. So this is just a picture of neonatal units, and I did a training for local ophthalmologists, and the service is still running. So this is like a quadrupeds I saw in Pakistan. So they are lying according to their birth weight from left to right. So they were born around 28 week of gestation. And the smallest was like 680 gram. Then this is 750 gram, the second from the right. And that was the only child, only baby who developed treatable ROP. The rest three, even the smallest one, the ROP was self-resolved. So the experience I got from Pakistan is there's some racial or genetic factors. There are different risk groups. Like in Pakistan, the much larger babies are more at risk, which were considered very low risk in the UK. So recording of documentation. So it is becoming quite standardized now, and recorded in the form of diagram, which is coded with different stages. Okay. And I'll go by one all the stages. So like stage one is demarcation line, which is just, it has no height, it is flat, it's just a color change from between the vascular and avascular retina. Stage two, when it becomes ridge, it is slightly elevated, again at the vascular-avascular retinal junction. And then the pre-plus disease, which was first described in 2005 classification. So it is slight tortuosity and dilatation of blood vessel, but still cannot call it frank plus disease. So this is like stage 3 with, you can see the fibrovascular proliferation at the ridge and then some elevation of vessels towards the vitreous cavity. And this is a frank plus disease with dilated tortuous blood vessels. And stage 4, which is divided into stage 4A, when the fovea is flat, like the macula is flat, and then stage 4B, when its posterior pole is also detached. So usually 4A start at the temporal side with the fibrosis of the retina. And stage 5 with a very poor visual prognosis, which can be open funnel when stage 5A. 5B is a no closed funnel detachment. So a picture on the bottom showing this white mass behind the lens, and that's what used to call as retro. So then indications are the zone 1 with any stage or no ROP with plus disease is indication of treatment. If zone 1, the stage 3, even without plus, is indication for treatment. And if it's zone 2 and stage 3 with plus disease, indication for treatment. I'll explain it later and we'll talk about the few other indications as well. So the initial treatment in 1970s was cryotherapy, which is freezing of the retina. Uh, and then later on, in 1980s, it started laser treatment, which is still a gold standard treatment for ROP. And intravitreal anti-VEGF injections are becoming more and more common, and they work very well. We'll discuss in treatments in further detail. And then for stage 4 and 5, the treatment is surgical. So the BDROP was the first trial to compare treatment of laser with anti-VEGF injection. So it shows superiority over recurrence, especially in zone 1 disease. So it's very important to be an aseptic technique. So it's done under topical anesthesia, but usually I take the patient to operation theater or do in a NICU in a negative pressure room. Iodine is very important for skin preparation, and even in the conjunctival space, diluted iodine. Then injection is given about 1.5 millimeters from the limbus, which is measured by caliper, and it's quite a quick procedure. And the ocular complication can be endophthalmitis, which is the severest complication and very serious. So sterility is important, and I try to use also different lot number of the medicine as well, so to reduce the risk further. So when we compare anti-VEGF with the injection with the indirect retinal laser, injection is easy to learn, very quick. There's no need for general anesthesia. Response is very quick. Within like 2 days, if you see the baby again, it seems like there's no ROP. So recurrence is very variable in different studies. In my experience, it's around 30 to 40%. So regular follow-ups are required for long term, which I always try to convince the parents even before the injection that it's recommended to have weekly follow-up for 12 weeks at least. And then now it's very advisable to do a fluorescent fundus angiography before discharging the patient from screening. And then the risk of endophthalmitis. On the other hand, laser, there's a long learning curve. It takes time. It can take from 1 hour to 1.5 for both eyes. Usually it's done under general anesthesia, can be sedation or topical, which is again even more difficult. Recurrence is not common, so it's reported around 10 to 20% needing further treatment. And high myopia, in my experience, it's less than 10% of the treated babies we have here. Constricted visual field, especially in cases when it's done in earlier gestation with a large area of retina avascular. But post-laser for reactivation when they do laser, there's hardly affecting the functional visual field. A rainbow study was published recently, which compared the 3 groups of using ranibizumab injection in 0.2 milligram dose, 0.1, which is extremely low dose, and laser treatment. So since it's published, ranibizumab is approved for ROP treatment in Europe. So there were 3 arms of the study, and all have like similar recurrence, a rate of 30% of retreatment. But many babies, they give a second injection in both first group and second group. They have like 12 cases of retreatment with injection. So another news now, this ranibizumab is recently, about 2 months back, is approved and licensed for ROP treatment in UAE. So we don't need to use any off-license treatment. Aflibercept has been used for ROP, and there are many studies. And this study I quoted is showing comparing both ranibizumab and aflibercept, and aflibercept has much less recurrence rate. I have only experience of using it in two babies with, and there was no recurrence. But the issue is the longer follow-up, and which can be challenging over here. Once the baby is well, it's difficult to examine. Parents don't want to come back again. So I'm quite reluctant to use. And now if it's ranibizumab is licensed, so we'll be using that for all treatments. So I'll give examples of few common cases of ROP. So this baby was born 680 grams, 24 week. Anti-VEGF was given at 33 weeks plus 6, and initially good recovery, but after about 5 weeks, there was a recurrence, which was treated by indirect laser. So the first two pictures on the left is showing the early treatable ROP injection was given. And you can see that this dilated tortuous vessel have recovered so quickly. This, I think the second photograph is within a week of first. And then the last pictures are of after laser treatment. Another baby, 640 gram, 23 week. At 37 week plus 6 develop ROP, given anti-VEGF, and there was no recurrence. Followed up for 12 weeks, and now got mild hypermetropia and doing very well. So this is a case seen recently, like this laser I've done on Sunday. 750 grams at birth, 25 weeks plus 1. So intravitreal injection was given early on 18th of April. This is post-injection data. And then after 2 months, now it's beyond 40 weeks of gestation, I think 42. And there is a restart of early plus disease. And the 13th was this picture taken, and then we review in within a week. On Sunday, we did the FFA, and it shows some proliferation there and had laser treatment. So there's another condition called vascular arrest, which can happen after anti-VEGF or can happen spontaneously also. In this cases, there is like a temporal avascular patch, not vascularizing babies beyond 40 weeks. So it's more common with anti-VEGF. So in these cases, it's also indicated to do laser if follow-up and examination is becoming difficult. So we usually do FFA, and at the same time we can do laser treatment. And this FFA is clearly showing this proliferation at the vascular avascular junction. So surgical cases, this one is 24 week, 610 gram. Had bilateral Lucentis injection, then bilateral indirect laser. It was elsewhere in another hospital, and then developed left retinal detachment, and that was referred to us. And then there was in the right eye further Lucentis was given, and right retinal detachment surgery was done. Later on, there was some vitreous hemorrhage which resolved itself. The retina got flat. Then later on, he developed cataract. So this is a clip from the retinal surgery. It's not. Yeah. So it is showing how stiff the retina is. My colleague who's an excellent vitreoretinal surgeon is doing the surgery, and it's all you can see in the periphery the laser scar marks already treated injection. So post intravitreal injection, there are 3 types of retinal detachment. All are difficult to fix. Like one is called that at the AV vascular avascular junction. There's a conventional RD elevation. Then there is a mid-retinal fibrosis, which is most difficult to treat. And there's also like posterior fibrosis in this case. So they are quite difficult to treat, and visual prognosis is poor. So, and this is a end-stage retinal disease with like funnel, close funnel detachment, total detachment, And even with surgery, the visual prognosis is quite poor. So this is 2019, we did an audit. We have seen about 11 cases of stage 4 ROP requiring surgery, which we perform. And we have, like in 2021, in first 6 months, we only received two cases. So either it's happening less or they refer to another hospitals. So the ROP workload was around 800 or more screenings I've done in 2019 with the 11 intravitreal injections and 16 laser treatment. So what's new is a wind drop algorithm. So this is checking insulin-like growth factor 1 with also birth weight. Sorry, weighing the baby regularly, which give an algorithm of the risk of ROP. Same is done by just independently checking insulin-like growth factor 1 and third week at that time, and then it gives a good prognostic tool for risk of ROP. So there was a pilot study for propanol, which shows some improvement. It need a further larger study with safety and efficacy. So artificial intelligence is also coming in play, and this is a landmark study done by Mr. Brown. So he used his RedCam3 images input into a computer-generated program, which check the blood vessel caliper and toxicity, and giving a report accordingly, and it has high sensitivity and specificity. In conclusion, I'll say that there's a need of more awareness among the medical professionals and parents with premature babies of importance of timely ROP screening and to prevent blindness. UAE has a very high standard of neonatal care and very premature babies are surviving. So like I'm seeing like once a year, like up to now in last 5 years, 3 or 4 babies, 22 weeks, but regularly 23 weeks on every round in both hospitals, and there's 1 or 2, sometimes more 23 weeks surviving. So in UAE, the fertility treatments are on the rise, and that's lead to multiple pregnancies, and that's causing more incidence of preterm babies and high risk of ROP. So newer technologies are coming for help, and Malafi is a new software which is we are using it in Abu Dhabi. It's a healthcare information exchange program for healthcare providers. So we're getting information from other hospital, other clinicians, and it's getting better over time. It started more than a year back, but now it's improving regularly. So there is national guidelines are being under development. So it's there is a ROP consensus guidelines steering committee. I'm honored to be a part of that committee. We are 6 pediatric ophthalmologists and 3 neonatologists, 2 retina specialists, and hopefully it will be published before the end of the year, and that will be for a national guideline published under Embassy Society of Ophthalmology. These are a few references. Thank you very much. Any questions?
Very much, Dr. Syed.
Thank you.
Question. So when you decide to do surgery on baby, how urgent it is? Within what time frame do you need to operate? Let's say stage 4.
Yeah, stage 4 is very urgent because surgery, and we have seen cases, I've seen with you, some cases which change overnight, like within 24 hours change. So we try to do it within 48 hours, preferably even 24 hours. So for stage 3 treatments, for like laser injection, the recommended in the guidelines is 48 hours. So, but definitely within 72 hours. So we try to follow this, but there's lots of challenges in arranging it. But definitely the surgical cases I've seen with you as well, which change like within 2 days from examination, going to operation theater, from partial retinal to total uh, becoming a fibrous ring at the posterior pole. Thank you. Any more questions?
Hi, Dr. Syed. I'm Dr. Neha here from Health Plus Albandar. Thank you for this presentation. Excellent talk on this topic. And it's very important for us, OB-GYN as well, to know more about this so that, we can counsel the patients in case they're going into preterm labor. And anything else that you feel that we should be talking to them about if they are going into labor or at that point?
Yeah, most important is checkup by ophthalmologist if they come into the criteria, and the follow-up, importance of follow-up. So if you can mention to them that the baby is born quite premature, less than 1500 gram or less than 32 weeks, it need a regular eye checkup. It's in majority of cases it is a preventable condition for blindness. So it is a treatable, preventable condition. So the blindness is preventable. So it's only need a regular follow-ups, regular checking, and treatment on time. Thank you.
Thank you so much. Thank you.
Syed, there's a question that's been asked. What is the success rate of injection treatment?
Yeah. So post-injection, there is recovery is very, very quick. And I've not seen any case after injection, the plus disease not resolved. So, but the main issue is the recurrence. So it's from 20% to 60% is quoted recurrence rate. In my practice, I think it's around 30 to 40%. And if it's a timely laser is done, can save the vision well. So, and then it's done at an earlier stage, so we get time for laser treatment and limited laser later on. So it is a very effective treatment. Only there's a risk of infection and endophthalmitis, which is a very serious risk. So we always discuss with the parents. Yeah. Thank you.
You heard about a technique called flying baby technique. Is this something that can be used in babies with ROP
Very
for
good.
testing?
Yeah. So that's, I think, the last. Okay, sorry. I can show you the picture. Can you see the picture on the screen?
Yes.
Hello? Yeah. So this is a flying baby technique. So it is used for examination on the slit lamp as well. It has been used for capturing fundus photograph. So it's a technique in which the belly of the baby is hanging on the forearm, leg and arms on each side, and the head is fixed on the instrument. Can do like OCT, and this is being optosis done. So it has helped us in many cases in which the disease is very peripheral. So with the contact camera, they claim visual field, field of view of 130 degrees. I think it's maybe slightly less, at like 110 degrees. But optos give a 200-degree view. So very peripheral disease, and it gives great pictures. I don't have it on this presentation, but I can show you. It gives more realistic pictures than a contact camera, and it shows proliferation in the especially stage 3 cases. And there's also a possibility of doing fluorescent angiography on this using this technique. And the latest model of like Optos has got it's called Silverstone. Has got also the OCT built in spontaneously. So that will be, yeah. So there's a doctor called C.K. Patel who has expertise in this technique and published a lot for all type of pathologies. Thank you.
Another question that's been asked, what type of laser that you use, and how many visits are required for a patient?
Yeah. So laser, I'm doing a diode laser. The argon laser can be another can be used to give equal results. So normally there are only like 2 or 3 visit post laser. The first one is like within 5 to 9 days, like first visit, then 2 weeks later, second visit. If it's regressing well, we discharge from screening that visit, maximum on the 3rd visit. So it's only 2 or 3 visits. In case of injection, there are 12 or more visits. Thank you very much, everyone. Thank you.
Any more questions?
Allah.
I think there's one in the chat box, Sonal.
Dr. Syed, someone's asked, what kind of refractive state is common in ROP babies, and what are the probable causes for this?
Yeah. So all premature children, there's a high risk of refractive error. So that's 20 to 30, like it's 20 to 30% higher than the normal like full-term babies. So we see all type of like high hypermetropia, or astigmatism, myopia, and there can be lazy eye is more common in premature, anisometropia, and squints as well. But for post-laser treatment, it has been noticed that there is some children develop high myopia. It's in range of like -9, -10 even as a baby. So this the pathology, pathogenesis is described as like the scarring the mid-peripheral retina cause some elongation of the globe, leading to this type of refractive error. In my experience, or in past like 10 years, it's not as common. I think it's because the most therapies are pre-anti-VEGF injection, because if we are doing laser of post-anti-VEGF injection, it's a limited laser compared to the one which is done for primary treatment at low gestational age. So our experience is only 10%, like if I treat 10 babies, it's hardly one or less than one get like high myopia. Thank you.
What other complications are associated with ROP babies?
Yeah, ocular complications. It's a complication for treatment and complication of the disease. Like disease can progress to stage 4, stage 5, which can lead to permanent blindness, which is not treatable. The complication for treatments, as I mentioned, for injections are like endophthalmitis, raised intraocular pressure, which we always look at retinal vasculature, like pulsations after the injection, and can develop persistent high pressure cataract, even with a very intense laser. Cataracts have been reported. There can be like accidental foveal burn with laser going too close to the macula, and then this is scarring can also affect central vision. So that's the main complication.